Hello again, and welcome to another episode of Fitness Facts. I'm Dr. Jordan Taylor, the Undergraduate Exercise Science Program Director and Associate Teaching Professor at the University of Kansas. Today, Dr. Sandra Billinger is in the studio to talk about stroke and the use of exercise in the rehabilitation of patients who have suffered a stroke. More specifically, we will also discuss some research she conducted that examined the optimal intensity and minimum duration of exercise that is needed to improve walking capacity in stroke patients in the chronic phase of recovery. Dr. Billinger is a world-renowned expert in exercise, brain health, and stroke recovery, and her work has been continuously funded through the National Institutes of Health since 2011 and has also received funding from the American Heart Association and the American Physical Therapy Association. She has published extensively and has delivered hundreds of lectures and courses nationally and internationally. At the University of Kansas Medical Center, Dr. Billinger is a professor and the vice chair for stroke translational research in the Department of Neurology. She serves as director of the Research in Exercise and Cardiovascular Health, the REACH Laboratory, and leads several multi-site NIH-funded trials and industry-sponsored research. Dr. Billinger also currently serves as the assistant director of the Neuroimaging Core within the KU Alzheimer's Disease Research Center. Her research initiatives have resulted in the following discoveries. 1, the development of maximal and submaximal exercise testing protocols on a recumbent stepper. 2, a novel method for assessing brain blood flow response during exercise. And number 3, a patent application. Welcome to the show, Dr. Billinger.
Well, thank you for that very kind and nice overview of my research.
It's been a while since seen you, and was it GRA and GTA helping you back in, 2009, 13, some odd years ago? So yeah, it's good to have you come in and talk today.
Well, it's great to be here, and I'm excited to talk about our study and the work that we do. So thank you.
Before diving into the discussion with Dr. Billinger, I want to provide some background information about stroke and define what a stroke is and how it occurs. It's estimated that someone has a stroke every 40 seconds in the United States. Approximately 20% of stroke patients die within the first few days. However, most patients survive with some long-term disability and various functional impairments. A stroke is the loss of blood flow to a region of the brain which results in tissue death. In as little as 5 minutes or less, a lack of oxygenated blood supply and nutrients to the brain can lead to tissue death and irreversible nerve cell damage. Loss of blood flow to a specific region of the brain can occur because of a manifestation of cardiovascular disease, which is characterized by the formation and accumulation of atherosclerotic plaque in arteries within the brain. Plaque that is formed in arteries may narrow these vessels enough to block blood flow in the brain, ultimately resulting in an ischemic stroke. In most ischemic strokes, a blood clot seals off the narrowed artery. Approximately 87% of all strokes are of the ischemic type. Although less prevalent, strokes may also occur due to a rupture of an artery in the brain and excessive bleeding. The excessive bleeding and swelling within the brain prevents blood from flowing to brain cells located downstream of the ruptured artery. This type of stroke is known as a hemorrhagic stroke and is more commonly seen in those with severe high blood pressure. When a stroke occurs, nerve cells in the brain die, and the resultant brain damage is the primary cause of functional impairment and disability in stroke survivors. Brain damage resulting from stroke can impair voluntary muscle movement, speech, vision, memory, and judgment. So let's kind of get into our discussion here, Dr. Billinger. What are the primary risk factors for stroke, and maybe talk about some of these that are common?
Well, you already mentioned hypertension or high blood pressure, so that's a very important risk factor to really think about how you can control that. Making sure you're seeing your doctor. Looking at high cholesterol is also a risk factor. We think about some of the things we can't control, such as increasing age, our genetics, what our parents give us for
family history.
Our family history. Yep. But the things that we can control are physical inactivity. So trying to really be active in our daily life. And, while we always promote exercise, we can also take the stairs, park further away, make sure that we're just walking and moving more in our daily life. And certainly diabetes also is a big risk factor, and obesity. And so as much as we can, we want to try to minimize those risk factors. And I always like to say, what's good for the heart is good for the brain. And so many times, all those things that we do to prevent heart disease also are important for people to prevent stroke.
Yeah, right. I mean, the same risk factors that you see for stroke are also risk factors for coronary artery disease, right? Yeah. So, and the last thing you want to have is damage in those vessels that are supplying the actual heart muscle with blood. You also don't want the plaque developing and the damage due to high blood sugar, due to cholesterol, narrowing those arteries in the brain, because those arteries are trying to carry that blood up to those neurons, those nerve cells in the brain. And and you mentioned physical inactivity. I know one of the things I definitely do get to the gym, but one thing I'm bad about is just sitting. I get really focused on my work, and I can sit at my desk for 5 hours straight. Right. And it's like, I need to get up and move. So, just little things like maybe set an alarm on your phone and get up and walk every hour for 5 minutes, and then return to your desk. Plus, you're going to probably be more clear-headed and more efficient once you set back down again, and you've actually got up and got that blood flowing and moving. But just little things like that you can do to get in some activity, throughout the day. And then also, I think another one I thought of is, a history of TIA, so transient ischemic attacks. Could you maybe talk about what that is? And I got a story to go along with that. Maybe explain what a TIA is.
Yes. A TIA is essentially, it's what we call a mini stroke. You may have some signs and symptoms, which we'll talk about shortly. But essentially, you've had this disruption in brain blood flow, but then it's temporarily gone, but then it's restored on its own. You don't need an intervention. And if you would happen to go to the emergency room, a lot of times they send you home because those symptoms have resolved. And so if you find yourself having multiple TIAs, that does put you at greater risk for having a much larger stroke down the road.
Yeah. And like you said, the key word is transient. So the symptoms typically resolve in 24 hours, 48, something like that.
24 hours. 24. They usually resolve less than 24 hours.
Yeah. And so you don't have actual permanent tissue damage like you see with a stroke. It's...
as imaging techniques are getting better, and the higher resolution, they're starting to see where those little pinpoint
little
damages
micro
are,
infarcts,
but they're like little micro.
Yeah.
It's really interesting to see that, because before we couldn't really see that on the screen. But it's just so small that they resolve, and so the tissue doesn't fully die in a large enough size as it does in a typical stroke. Right. That leaves people with those deficits.
Yeah, it's not like it undergoes that liquefactive necrosis where the tissue is dying, like in a major... In a large stroke. But I was thinking of the story I had is with TIAs is my grandma on my mom's side. Unfortunately, she's passed, but lived a pretty long, healthy life. And I remember as she got into her 80s, she started having a lot of TIAs. And, my uncle would find her, I remember one time he was over and he felt this boom or heard this boom upstairs. She had passed out, woke up, of course, was confused, slurring her speech. Out of the emergency room, had a TIA, but she started having many of these. And I remember telling family members, I was like, unfortunately, I think grandma may go because of a stroke. And basically, she had one. I mean, she survived it, but not too long after the stroke, trying to go through rehab and get through all of that. She passed away. But the TIAs, when you start seeing those, I think, that's obviously another one of those risk factors. But a lot of people confuse TIA with an actual stroke. So thanks for clearing that up.
And I do want to, give a shout out to our colleague, Dr. Katie Singh-Sukan. So she really promotes sleep health. And so also if you have sleep apnea, that's also a risk factor, because during the night you can stop your regular breathing, or there's periods of time where you're not breathing. And so that low oxygen levels to the brain can actually be a risk factor and cause some vascular damage in the brain. So sleep health is really important, along with physical activity. And, these all tie together. People who are more physically active tend to sleep better. When you sleep better, you feel more energetic and will do activity. And so it really all goes hand in hand.
And I know, like we talked, you mentioned how the heart and the brain are so intimately linked, and we talked about on the way over, to have healthy brain cells, you've got to have healthy blood vessels. They're like best buddies, right?
Yep.
And of course, the heart is the pump getting all that blood up to the brain. But, my grandma, I think of her case, it was being medically managed, but she had atrial fibrillation, which is where the top chambers of the heart kind of quiver. They're not really getting that blood down to the ventricles. And, that atrial fibrillation is tied in with TIA and stroke as well. Yes. So, because obviously, an issue with the heart can lead to issues up in the brain. So
that is, yes, very true. We always say in the physical therapy world, vitals are vital.
Yeah.
So that's a hashtag on Twitter if you're interested in following more about risk factors or learning more about how you can manage heart disease or stroke. We try to promote that to always know what your values are and see that you're a physician regularly.
Great. Well, let's talk about some of the signs and symptoms of a stroke. So maybe we can pull up that picture 2 here. So you maybe want to get into some of these. If what can people look for? Let's say they're at a family dinner, whatever, and somebody's just not acting like their normal self all of a sudden. Yeah.
Yeah. So, one of the things that American Heart Association has done really well, they came out initially with FAST. And this was face, arm, speech, and time, and that's time to call 911. We like to say brain is time. But we also know that some of these other risk factors, they now do be fast. And so they've added balance and eyes. So again, if you feel like you're moving in your day-to-day and all of a sudden get a little foggy or lightheaded, maybe you have a slight headache or feel dizzy, and you just feel a little off, really monitor that. And again, if it's unusual and you're not sure what's caused that, it might be a sign of a stroke. Some people lose vision in their eyes. The vision gets blurry, and I know sometimes people with contacts or maybe glasses, or you've been at the computer, you might think, oh, my eyes, I've just been reading a lot and this will go away. If it doesn't go away after a period of time, you should really, again, if this is sudden and it's an onset and you're not sure what it is, it's better to be safe and go get that checked out. If you think about face, again, so the F and be fast, a lot of times when we have people, smile, and so if you smile, it should be even, and if one side doesn't or droops, that's usually a sign of a stroke as well. Sometimes people will even report a little bit of numbness or tingling in their face. So again, with that sign or symptom, arm weakness. So put your arms out nice and straight in front of you. Yep. So see, these are nice and even. Yeah. And sometimes with a stroke, that it's a lot of time is maybe even less. They can't lift that arm when they're trying. And this, I will also say, could be in the leg. Yeah. So let's say you get up from a chair and you stumble and you feel a little weakness and you can't move that leg. Those are some other things. You'll probably lose your balance again if your leg muscles aren't working correctly.
Right, and typically, and kind of jumping ahead, but you're going to have that weakness or maybe full paralysis, depending on the stroke. It's going to be contralateral or on the opposite side of the body of the hemisphere that the stroke occurred in.
That's true.
So it's like if you have a stroke and brain damage to those nerve cells in the right hemisphere, maybe in the motor cortex, which is responsible for sending out the signals to move the left side of the body, well, then you're going to have impairment on that left side, right? So it's always opposite, tends to be of the region of the brain where the stroke occurred.
Yeah. And then the last one would be speech. And so again, if you're, whether you're in the conversation, you're that person, or you're hearing somebody talk, if all of a sudden they slur their words or they're not able to form words or it's incoherent. So if you asked me a question and I responded with, the dog ate my shoe, and you didn't ask me that type of a question, they can't find the correct word, or other words come out, or they just can't, their tongue's not working, and it just sounds very different. Again, I think these are all signs and symptoms of stroke that we want to be aware of. And again, as I said, time is brain. We want people to either call 911 or get to the hospital as quick as they can, so that they can get treatment.
Right, right. Yeah, and then looking at some other things here. If we pull up this next picture, I'll talk a little bit about that. So picture 3, So this image just shows the functional areas of the brain. I'm not going to go through all of these. We can talk about it in my classes if you're a student, but deficits in function after a stroke depend on what cerebral artery is affected. Because remember, these arteries are supplying blood to the actual brain tissue. So just like if you think about, we came over on I-70, there's all these interstates around Kansas City. If there's road construction or damage or a blockage on the road, well then the traffic, which is like blood, can't flow through, right? So similar in the brain, if you have a clot, if you have some atherosclerotic plaque, and there's something that's impeding blood flow, oxygen, and nutrients to these different areas, then that can always obviously lead to a stroke if blood supply is disrupted for long enough, right? For minutes, all right? Now, where the damage and the symptoms that you have, it's going to be correlated to where the damage occurs in the brain, right? So if you have a stroke, like I mentioned, this is the left hemisphere. We're looking at the left side of the brain, kind of in that red area. You'll see like a number 4 there. That's the primary motor area or primary motor cortex. So there's all these neurons there that send down axons, these long tracks down the spinal cord. Many of them, about 90%, cross over to the opposite side of the body. So since this is the left hemisphere, about 90% of those are going to cross over to the right side of the body, control movement of the right arm, the leg. And if you have a stroke there in that left hemisphere motor cortex, then that's going to cause the weakness or paralysis on the right side of the body, right? So the symptoms you see are going to be correlated or associated with where the damage is. Maybe you have it there in what's called Wernicke's area, outlined by the dashes there. You'll see number 22. So this area is responsible for allowing you to understand and comprehend language, whether it's written or things you're reading or someone talking to you. That area helps you make sense of language. So obviously if you have damage there, there's tissue death, then you're going to have trouble understanding what someone is saying to you. You're going to appear confused, right? Maybe it's in Broca's area. They're in another outlined red dashed area there in the frontal lobe. Again, most of the population, Broca's area is in the left hemisphere, a high percentage. And so if you have damage there, you're going to have trouble producing speech and language. Okay, so again, whatever your signs and symptoms are, it's going to be tied to the area of the brain where there's damage, okay?
Yeah, I'd like to add, some people have cerebellar strokes too, and that will really affect your balance. So the, kind of the goldish brown color on that figure, we see a lot of people have something that we call ataxia. And so again, most people can put their finger to their nose and we look at that. But if you have a lot of ataxia, you might do something like that and miss. And so again, the cerebellum can be affected. You can have a brainstem stroke depending on the artery. And so a lot of times, again, if it's not severe enough, you can see abnormal respiration because those centers are then affected, and you can have an irregular heart rate as well with that. And so, again, stroke is very heterogeneous, and so, no stroke necessarily looks the same, even if it's in the same area.
Right.
So the size of the stroke, where it is in those different locations, people present very differently. And
right.
So, it's very interesting, and you can have, you spoke about all the motor areas, but some people can have strokes in the white matter, and those are a lot more challenging
like
to
the
recover
strokes.
from. Yeah,
deeper down in the brain.
Yeah. So the stroke's very heterogeneous. And this is why we talk about prevention a lot, because it can really affect our daily lives. And I'd just like to add that stroke is, one of the largest contributors to long-term disability in individuals right now. And so a lot we need to do to either prevent stroke or help people recover from that.
And unfortunately, like we talked about on the right over, you're seeing it younger and younger. And people in their 20s, and we used to always think, oh, this is something that happens, once you're over 65. And it's not. Seeing it more commonly in younger individuals. And to go back to your point about the cerebellum, that is so true. It's like, I think about the function of the cerebellum. It's really, it's not so much an initiating movement like the primary motor area or cortex. That's what says go, make a movement, is the primary motor cortex. But the cerebellum is really important in guiding, directing movement, like while it's happening, movement accuracy and timing. So that plays a big role. So obviously you're going to have issues with all of those things if you had a cerebellar stroke. And then
I think of the fine tuning.
Right.
It kind of fine tunes
adjust your movement.
Yeah, make sure you get to that designated area, just like picking up a water bottle and taking a drink.
Yeah, that motor cortex is saying, hey, go reach for it. The cerebellum's helping guide you there. Yeah, and plus with the basal ganglia and some other structures, but they're getting way off track. And then, you mentioned brainstem stroke. I think about it's very interesting. A lot of times, I don't know percentages, maybe you could quote, but if you have a severe stroke down in the brainstem, which you kind of see there at the base, it's composed of the midbrain, the pons, and the medulla oblongata. I always think of that professor in Waterboy, medulla oblongata. But if you have a stroke down in that region, a lot of times people die from that if it's large enough, because like you mentioned, you're a lot of the autonomic processes that you're not consciously aware of, they're kind of housed there, like the centers for breathing and controlling heart rate. So that's kind of one of the last spots you would want to have a stroke. I know my mom actually had a small brainstem stroke, and very small. I mean, she obviously survived, but I remember her talking about one of the symptoms was like, all of a sudden she couldn't see.
Yeah.
And was, I think, at an intersection in her vehicle.
Oh my gosh.
And had to pull off the road. Like it was no vision. Again, it's one of the symptoms, but
yeah. Oh goodness, yeah.
So
I'm glad she did okay.
Yeah,
that's great.
Good. Came out of it. So all right, so let's move on to talking about if someone is experiencing these signs and symptoms, and obviously you said, it's so important, we got to get them to the emergency room. How is the physician, the attending physician, they're going to typically diagnose this?
Yeah. So if you come to the emergency room, what they are going to do is they might get you into an MRI to look at the brain tissue. Again, if you're showing any signs and symptoms at all, they're going to want to, really look at the brain and see what they can see. They may do a CT scan too, especially if you're showing signs of a hemorrhage stroke. It shows up better on the CT scan. And the reason that they're looking at doing that is if you have a bleed, they don't want to administer TPA, which is tissue plasminogen activator, because that actually thins the blood in that case, and so they're not going to want to do that. So one of those imaging is what they'll do, and sometimes they'll do angiographies as well if they want to just really look at the vasculature and see maybe if it's in a smaller vessel where that clot is and things like that. But if you're going to the ER, a lot of times they'll get a CT scan or a follow-up MRI to really confirm.
Yeah, and that's a good point you made about the TPA. It's like, the physician has to determine, is this an ischemic stroke where there's a clot that needs to be busted? Yeah, then maybe they administer the TPA to break that up, to try to break it up. But yeah, if it's a hemorrhagic stroke and they've literally had a vessel that's burst, the last thing you want to do is thin out the blood and enhance the bleeding. And, you think about the brain is encased in the skull, and there's not much room for it to swell. So if you're having a lot of bleeding in there, and then for some reason you make a mistake and give TPA, then that's going to enhance the bleeding, and you've got now increased intracranial pressure and now even more tissue death as a result of that, of an improper treatment, which, that's obviously why the imaging is done. And
Yeah, they're really good at managing that when you go to the emergency room. They're going to ask signs and symptoms and really try to get an idea of, what's been happening, what's your risk factors. If you have hypertension again and you have had this gigantic headache all day long, my guess is they're going to start to think hemorrhagic stroke, and they'll do a CT scan right away. If you have hypertension, heart disease, maybe you've had a history of stents in your heart due to clots, atherosclerotic clots, then likely they'll think, ischemic stroke. And again, they're very, really great at seeing those, the signs and symptoms and getting people treated right away. And, and I don't have the stats on over here in Lawrence, but I know the hospitals in Kansas City are really great at really getting fast times to treatment. Those are part of, the stroke care and again, what we call door to needle time and trying to get people treated.
Right.
They really are getting so efficient in all the tools that they have to detect that and diagnose what you might have.
Well, but I was just thinking about this too, with the way it's diagnosed, the different techniques. I mean, generally a CT scan is quicker, than an MRI. And, you know, we think time is brain tissue. You need to go in there and you know, it's got to be treated, whether it's mechanical thrombectomy, they go in, whatever the interventions that's used. But it's like the quicker you can determine what's going on, the more brain tissue you're going to save. So I know that, you know, the MRI is higher resolution, but it can take longer. So
that's why they start with CT.
Yeah. All right. So then how are strokes kind of initially treated and medically managed once it is diagnosed?
Yeah, you know, I think for people who have a bleed, they're going to go in surgically. They're going to want to, you know, repair any damage if that's the line of treatment. Or maybe they don't and it's small. And sometimes those bleeds will resolve on their own with medical management. A lot of times they'll bring down blood pressure with antihypertensives. They're going to use different drugs. You know, again, if you have thicker blood or, you know, you might be on antiplatelets or you might be on now, for, you know, warfarin forever, which is a blood thinner. A lot of people are on blood thinning drugs, and that's just to help the blood not get sticky or clot. And so that way, you know, through those small vessels, blood's going to flow through that. So yeah, that's definitely some medical management.
All righty. So can you talk about the general timeline of recovery after stroke? What's occurring in the brain during each phase? And when does a patient begin rehabilitation? So we'll maybe pull up this picture. I think this will kind of help. And this is just in general. I mean, not every stroke patient is going to follow this exact timeline, but just in general to help the viewers kind of understand what's occurring in this acute phase and then on out to the chronic.
Yeah, so, you know, we on the slide here, there's hyperacute, and that's really the immediate stroke. I mean, we're really working to try to minimize damage to the tissue, try to get things stable in the brain. And so a lot of times in those first, those early first 24 hours, you know, we're trying to get people stable. And I just want to, you know, talk about there is this idea, and it had really, and I think as you're aware, in the animal model, there's been some suggestion, you know, that maybe we need to look at, you know, in that first 24 hours, once somebody's stable, getting them up and mobilizing them. And so one of my colleagues from Australia did this large multi-country 2,000 people person, almost 3,000 person study around the world. And what they found is advanced and intense mobility is not good for people with stroke. So that 0 to 24 hours, we might get them sitting up, but not aggressive rehabilitation. And so again, it's really important to get the brain stable, get blood pressure down, get all the, you know, everything managed medically. So you may get out of bed, but not intensive therapy. During the you know, after 24 hours, we're going to start getting people up, starting moving them again, doing some walking, doing your activities of daily living, trying to get people up. Now, the acute says 1 to 7 days, and that may actually be from a physiological perspective of what's really going on in the brain. But from a rehabilitative perspective, you know, the acute phase, depending on the stroke severity, could be 1 to 3 days, and they may move you then to inpatient rehab or skilled nursing, or some people go home. They, you know, recover. They don't have many deficits. Again, our treatments, our medical management is getting so much better that, you know, people do go home, and that's a great. Those are great success stories that we love to hear about. But yeah, so in those early days, we'll get them up, do rehab. They're, you know, the nurses are managing them medically, the physicians making sure everything's stable, vitals monitored, things like that. And then once you go to that inpatient rehabilitation, which is, you know, again, you know, these are general terms. So some people might be in the acute unit for a week, maybe 2 weeks if they've had surgery. So it just really depends. But in a typical case, you know, within 4 to 5 days, usually we want you to go to that inpatient rehab. And this is really in this early subacute phase, we really feel like we want to really maximize neuroplasticity. We want to maximize recovery. And so we're going to get people up to do a lot of task training. We're going to work on your balance. We're going to try to help get your strength back. Really manage those activities of daily living. So going to the bathroom, brushing your teeth, combing your hair, feeding yourself. So all of these things are really important. And again, I see on the slide it says endogenous plasticity, which I know you're gonna give a nice overview of that. But again, how we recover from that, and again, the thought is the more we can practice things, the better that we get. And then we have, late subacute is 3 to 6 months. Again, we do see a lot of benefit to therapy, outpatient therapy, and being able to practice these tasks. Again, fine-tuning our movements after stroke. And then chronic is definitely greater than 6 months. Now, 10, 20 years ago, we thought, well, you've had this stroke and, you might not be able to improve, but our research has refuted that. We can make a difference. So for the viewers, if you know people or if you've had the stroke or you're just interested in stroke, don't give up. Keep practicing. You can make gains after 6 months post-stroke.
Yeah.
They may take a little bit longer. Recovery may be a little bit slower, but don't give up.
Yeah, that's important. I think a lot of, and it's really great that research has come out, but it's like, keep challenging your brain. I mean, maybe you had a stroke a year, 2 years ago, but it's like, try to learn new things. Maybe pick up doing some artwork or learning a musical instrument or something new, so you challenge those different neural pathways in the brain. Because it's really amazing how, like you mentioned that word plasticity, and I'll talk more about it in a bit, but it doesn't mean the brain's plastic. It just means it's amenable to change, and it can change based on the environment and what it's been exposed to, both extrinsically and intrinsically. So that can play a huge role in how you live out the rest of your life, right? By exposing it to new and challenging things. And then, like you mentioned with rehab, now, when are people going to see the biggest progress? Like if we look at these phases, right? Is it, when are they going to see the most improvement in their function and overall, just getting better from it?
Yeah, we like to think about it as that 3 to 6 months period as really a time. But, we don't have enough research to definitively say this is the time. There's been some early research by a colleague who really did this great study that suggests maybe that inpatient rehab, that 7 to 30 days is optimal. It's just challenging to really study that because of, again, people want to go home. They don't want to stay in that necessarily maybe in the hospital and if they can go home and do therapy in outpatient or home health. But there is some beginning evidence that maybe 7 to 30 days, if we can really do some intense therapy, that may be optimal. But again, there's a lot of things that we have to consider. And again, if patients aren't sleeping well, they're tired, they're fatigued, they may not want to do that intense therapy. We may have to go a little bit slower for some people. But again, I would say anywhere from that 7 days to 30 seems like to be a peak for improvement. And then also that, around 3 months is also a time to really push and try to advance, the things that you're doing. Yeah.
Okay, so 7 days to 3 months. Yeah, important there.
Yes.
And you can kind of see that on the graph. That's where some of this plasticity is really, that green line is peaking, and you see the orange line, the improving impairment and function over time. And then I'll talk more about that plasticity in a bit.
And, we don't have to go back to the slide, but, I'd also like to add those risk factors that we talked about early. Again, your vascular health, your heart health, all of those risk factors make a difference. And physical inactivity, when we've had people who come in who, maybe they just have a stroke for some unknown reason or have a weakening in an area and have a bleed, but they exercise, their recovery, we do know they do better when they're more active before. So again, we talked about heart health for brain health. If that brain is a little more vascularly healthy, you actually do recover a little bit better than somebody that has more risk factors and maybe their brain health is not optimal. So just thinking about those things and how quickly all the things that can contribute and the choices we make over time.
Yeah, you talk about the brain being more vascular. I know when I was at the Med Center and doing my traumatic brain injury research, and of course I was looking at a mouse model of traumatic brain injury, but I looked at some proteins that were upregulated as a result of exercise. So these animals had exercised for like 6 weeks, and then I was looking at different areas of the brain, like the hippocampus, where you basically it's important in memory formation, and the motor cortex, again with movement, and saw an increase in proteins in those areas, like vascular endothelial growth factor was one that was upregulated. And that's important for forming new capillaries and giving you a bunch of supply routes for blood to flow to those neurons, right?
Opening up traffic.
Right, you're opening up traffic flow. Increase VEGF, you exercise, you increase that vascular endothelial growth factor. It helps build more roads or capillaries throughout the brain, and you got more blood flowing to your nerve cells, which is what you want. But yeah, I mean, it's really amazing how, prophylactically you see that benefit with exercise, and then in recovery as well. It's so important. So, and it reminds me of people that, that had heart attacks. It used to be that, they keep them on bed rest for an extended period of time.
Yeah.
I mean,
the
days.
60s,
and then,
it was 30 days.
Yeah. Then now it's like, no, we're going to get up. We're going to get you walking around and moving. I mean, the exercise isn't going to be any more traumatic to the heart than what just happened, right? I mean, you restore the blood flow. All right, let's get you up. Let's get you moving, right? So, all righty. So basically, and we kind of hit this home already, but the sooner, the earlier stroke rehabilitation begins, the more optimistic the patient's prognosis will be. So can you discuss some of the therapies that are used in stroke rehabilitation to improve patient outcomes, and then what the goals are of stroke rehabilitation, and maybe what you feel is overlooked? There's a lot there. There's a lot there. Maybe we should just start with the first one. So therapies.
It's great. Yeah, no, it's, again, we take a team approach. So you're going to work with a physiatrist. We're going to work with social work. We're going to work with nursing. We're going to work with physical therapy, occupational therapy, speech therapy. So our goals are really to return people to their prior level of function, which is what most people want.
Yeah.
They want to return to, they want to be able to feed themselves. They want to be able to cook. They want to be able to go to the bathroom by themselves. Then, walking is always important. They want to be able to get around, be a part of the community, whether, if they have, some type of club, or if, church is important to them. If they have art or whatever they do, they want to be able to be out in the community. And then driving is the other one, to return to that. And so, the role of the physical therapist, and while I don't like to separate us into, PT does legs and OT does arms, we really try to take this team and holistic approach. But physical therapy a lot of time is working on balance, walking activities. They may do some dressing or tasks, putting on your pants while standing and working on your balance. We're going to do some walking, maybe on the treadmill. They might do, balance activities, put you on foam, and really try to challenge you in those activities. And then OT is working on activities of daily living. They may want to work with you on feeding yourself, brushing your teeth, combing your hair. They'll work on vision too, a lot of different things. And then the speech language pathologist is going to work on communication. If you have aphasia, where again, you're not able to either form words, or maybe you have difficulty, they're going to work with you on that. They might work with you on money management. But if you have to take this team approach, and I know that the OT is working on brushing their teeth, I may have them brush their teeth, but have them stand on foam and work on their balance while they're doing movements, because we don't just do anything in isolation. We are dynamic beings, and so we do multiple things at once. Or maybe I know the speech language pathologist was working on communicating. So maybe while they're doing balance, I'm going to have them tell me a story or talk about their family. And so again, our goal is really to restore movement, coordination, all of the things that we can.
And when she says I, she's speaking from experience, because she is, now a researcher, a Ph.D., rehab science. We have the same Ph.D. actually. Yes. But she's also a PT, so she can speech from the research side of it, and then also just that practical experience, right? So
my clinical training is in physical therapy, but yes, I like you. I'm curious about science and all the things, and so got my PhD.
I just wanted to make that clear. So it's like, yes, when she says I, she is speaking from personal experience working with patients, yes.
Yes.
Anything you want to comment on any of these other therapies that you think are really cool or that have a lot of research backing them? I mean, there's things like constraint-induced movement therapy, and there's things like mirror therapy, using robots now to assist in therapy, and transcranial magnetic stimulation, and I mean, just a lot of different things. I mean, do you have any any comments on any of those? Now we're getting really advanced, but like brain machine interface. I mean, it's just the technology is advancing. There's just so many things that could, I think, really benefit patients with a variety of different diseases. But maybe your thoughts on just any other therapies?
Sure, yeah. I think, we try to do a lot of different techniques to try to really help people as much as we can. And it's been really interesting. There's been some big trials, but at the end of the day, the physical therapist or the OT has still been, some of the best. We haven't had, some of the, big trials that have suggested, the robotics are necessarily better, but they are adjunct to that, to really help. So for somebody that's really learning early, they may need the robot assist and be able to get up and work on their balance early in a way that, again, maybe the therapist can't lift them or, hold them. You got to kind of balance that. But once you can get moving, then the therapist can really drive that forward. I think where robot-assisted therapy is great is if we can get them in there and help with the repetitions and the movement. The American Physical Therapy Association, the Neurology Academy of Neurologic Physical Therapy really pushes intensity matters. They have a new push for therapists to really think about, intensity and dosing, which I think we'll talk about later in the research part of it. But that can really help with the constant repetitions that maybe the therapist can't do, or we can have them do it in their room or, independently, where they can help with that movement so they can get more practice in.
Right.
I think, some of the other techniques, transmagnetic stimulation. There's a current national trial ongoing in NIH-funded StrokeNet, which is a network of hospitals across the United States that are right now testing it. What's the optimal current? Is it better than therapy? Do we need to combine that with therapy? And so I think we just don't have all the answers yet. There was a big study, early on where you took if your right hand was affected, we constrained it and, tied it down and forced you to use the other limb to try to practice and do all of these things. So we're still in what I would say a very young and early phase of this type of research. And so if you're interested in this, there's just a whole push and going to be the next 20 to 50 years is going to be really important because, I'll kind of age myself here, but in the 90s when I was reading textbooks about the brain and really getting into stroke rehabilitation, they were all saying the brain wasn't plastic, which meant it couldn't rewire. And now we just think that's so silly. Yeah. But we didn't know about all these things. And so if you think about a profession, cardiac's been really looking at recovery of heart since the 60s. We're like 2000s where we started really pushing the science in stroke recovery. We just thought, well, these are the deficits and this is what you have. But we've learned that that's not true and that the brain actually can rewire itself. You can learn new things. So, we're still walking, should I say walking intended, pun intended here, walking through things to try to find what is the best therapy for people. And you asked me what is underutilized. It'll be your and my favorite, exercise. Yeah. I think we need to do more, and so we do have some trials underway, not just using a treadmill, but a stepper device, and that I really believe that exercise has a bigger role to play in stroke recovery than what I think we've realized to date. So, but we need to test that and find out if that's really true, and we're hoping to keep advancing that area. Yeah, and I have a buddy, and I know he won't mind, but Tony Kiondongse from the gym I go to, and it's amazing. He had a stroke. I think he was in his late 20s, and he does powerlifting now. And he's really good at it. Competing, but again, he really pushed hard in his rehab, got back into the gym. His mindset was, I'm going to conquer this. And now it's amazing. And it's less and less of a deficit I see between the one side of his body and the other side as time has passed. And he's doing really well. So shout out to Tony. But anyway, let's talk a little bit about, is there anything else you want to mention with therapies? Or should we move on to the next point? I think we should move on, yeah. So I'll talk a little bit about neuroplasticity, and then you talk about, and you've kind of hit on it a little bit, how stroke rehab can drive this process in the brain.
Okay, so we'll pull up picture 5 here. So, neuroplasticity, as you can see there, it's commonly categorized as either structural or functional. Structural neuroplasticity refers to physical brain tissue remodeling in response to learning and new experiences, whereas functional neuroplasticity occurs when existing neurons, which are nerve cells in the brain, propagate and form new synaptic connections after functional loss following injury. So let's just kind of break down this word plasticity. What is that? Like I said earlier, it doesn't mean that the brain is plastic. It means the brain can kind of be remodeled and molded like a piece of clay, or you can think about it almost like a plant. It's amenable to change based on new experiences, what you expose it to. Like I said, learning a new musical instrument, is it you start doing crossword puzzles. Maybe you're, you travel more and see new things, and you're just exposing exercise. Obviously, you're exposing this brain to new things after you've had a stroke, right? And there's different ways that the brain can kind of remodel, rewire to become more functional because of what it's been exposed to, all right? So some of this is, like you see there under structural neuroplasticity, you see a couple neurons there. More neurons and synaptic connections are formed with learning, memory, and experience, right? You practice a task over and over. It's going to strengthen those synaptic connections. So a synapse is where one neuron, like neuron A here, if you think of my body, my torso is like the cell body of a neuron. This arm is the axon where an electrochemical message is sent down it. And then my fingers are like the terminal end of this axon. And you have these little synaptic knobs, and they're going to connect with another neuron, which could be, say, this other arm, right? And that's where the message is relayed, at the synapse. So you have a strengthening of those synaptic connections with more learning, practice, learning new things. And that's creating this physical change, this structural change in the brain. You also see things like maybe there's been some damage to the axon because of the stroke, which is, again, this wire. You can think of it as a wire that's sending a message down to the synapse to relay it to another nerve cell. Well, if there's been some damage to the axon, we now know that axons can sprout. They can kind of branch out, like you might see branches on a plant forming or a tree, and then they can make new synaptic connections and form new synapses with other adjacent neurons, and maybe you kind of have a little bit of rewiring going on there in the brain, and that's another form of structural neuroplasticity. Functional neuroplasticity is where, let's say you have a stroke and you've got some neuron cell death, because that happens with a stroke, but there's still existing healthy neurons in the brain. And I don't like it there at the bottom of the box on the right-hand side. It says new neurons. With functional neuroplasticity, it's the neurons that are already there. They take over the function. So some brain cells take over the function of what the brain cells that died were doing previously, right? So it's kind of like this. I'll use this analogy. Let's say you're a single mom, you're busy, you got kids, you got to get dinner on the table, you're working 2 jobs, whatever, you have no time, you're burned out, you feel like you're dying, right? So you're this one nerve cell that's just dying out. But you realize you got some friends in the neighborhood, other nerve cells, right? Your friends, they're willing to help out, right? So they come over, maybe help cook a meal, run the kids' hair, run them there. Hey, bring you a glass of wine. Hey, take a load off, right? That's basically functional neuroplasticity. You're the dying neuron as the single mom. Everyone else in the neighborhood, your friends, are helping you out, and they're taking over some of your daily functions, right? And so this can happen in the brain with what you expose it to, right, over time, like a lot of the rehab. So maybe talk about the rehab then. I'm going to turn it over to you now, since I went on this whole spiel about neuroplasticity. Yeah. How can stroke rehab drive this neuroplasticity in the brain?
Yeah. So I'm going to back up a little bit on the structural plasticity. And, when you think about learning new things, you don't get to be Patrick Mahomes or Michael Jordan and those super athletes without learning. You practice over and over and over until it just becomes part of the natural movement, right? And so that's the brain learning these skills over time, whether you start as a kid or, people who play multiple sports, their brain has just, really kind of absorbed all this learning and doing that. So that's how all of that the plasticity, that's everything you learn. People listening right now, they're hearing new information, and so their brain is taking this in and processing it. And so, that's all structural neuroplasticity. When you're learning, experiencing new things, trying new things, if you decide you don't like it and quit, your brain will have a little bit of that pathway. But if you really enjoy something, you practice over and over and get better, that's how those neurons all connect together and form that.
It's like the old saying, neurons that fire together, wire together, right?
That's
We've
nice,
heard that
yes.
so many times. It's like, so there's a strengthening of those connections.
Yeah.
When you're doing this activity over and over and you really learn it, you have those strong connections. Yeah.
And then you become so focused in learning, but then when you really master it, you don't have to think about it as much anymore because you've learned all of this.
It's what's called an implicit memory. Yeah.
So related to functional neuroplasticity, when we think about rehab. So again, as I gave the background on the athletes that practice over and over, they have to practice to get better, and that's what they do. And so a lot of this in therapy, when we talk about intensity matters, or you'll hear high repetition training, or mass practice, doing it over and over. This is the idea of practicing to get those neurons to really want to rewire, create new connections, and then rewire together and stay together, right? They want to build that bond between them so that they can really work together for that movement. And that can be either, again, practicing arm movement, speech, word formation, walking, any of those tasks that we do, we just have to practice them over and over.
Yeah.
And so, and again, I think with stroke, it's hard because this has been like this sudden event that's happened. You were fine yesterday, and now you can't talk, maybe you don't understand, your arm doesn't move the way, and it gets really frustrating. And I think, it's hard to be patient in that recovery because you want to get better so quickly. And so you just have to give yourself time, but it is that practice over and over.
And you look, and that's something to be mindful of, especially any of you students that are going to be PTs, OTs, neurologists working with patients, but it's like, try to put yourself in the place of that patient. I mean, think about that frustration they're dealing with too. I mean, because think about somebody there's different types of aphasia, but they could be understanding what you're telling them or the instructions when you're going through rehab, but they need to tell you something and they're struggling to verbalize that and get that out. I mean, maybe they're in pain, or I don't know, they need to go to the bathroom, or they're hungry. They're just, they don't feel good that day, but you're trying to kind of push them through therapy and they understand your instructions. But because of the part of the brain that's affected, they can't verbalize that they may need to stop or what they actually need. So there can be frustration on both the patient's part, the therapist's part. I mean, it's tough, but
it is. But we work together as a team, and our end goal is always to get people functional and independent and back where they can. And so again, one of the things we didn't talk about, I would love to see stem cell therapy or some type of cell regeneration that, there has been some trials and they're working on that just to see how they could facilitate that to try to help recovery as well.
Like I know, and there's different molecular targets in the brain. I know some research, and I can't remember what lab it came out of, but the stem cell therapy just made me think of this. My brain is going down into brain cells now, thinking about inside of them. But GDF10 is a protein that helps to spur some of this axonal sprouting and synaptogenesis, forming these synaptic connections in the brain. So, identifying those molecular targets and strategies is very important in research. And they probably move on to our next discussion topic. So now, just what do you recommend for stroke prevention?
Yeah.
So we don't have to have one in the first place, right? What are we going to do to prevent it?
I think, again, thinking about those risk factors that we talked about at the beginning, hypertension, staying active, getting good sleep, I also say know your numbers. So what's your blood pressure? What's your blood sugar? What's your cholesterol? And being mindful of those things and really trying to be active and eat a good, healthy diet. And again, I'm not sure that there's, the diet. I know they've talked about Mediterranean diets and things like that. But, growing up in Western Kansas, the Mediterranean diet wasn't something we did, out there. And again,
steak, taters, and corn.
So how can you incorporate more vegetables or more fruits into that diet, and thinking about good healthy fats such as avocados and nuts. Almonds, walnuts are really are good for nutritional value, and also being sensitive to what different people's backgrounds, whether it's race or ethnicity, and again thinking about what foods are healthy in their culture of diet. We have a colleague who's really looking at a brain healthy diet in the African American community, and so looking at a diet that's culturally tailored to the African American community, and again because not everybody wants to eat a Mediterranean diet, and so some of these things, making these modifications, you can find alternatives. And I just want to give Dr. Ashley Shaw a shout out, because I think what she's doing is fantastic work. She's speaking to the community and what they want for brain health, and trying to come up with a diet that's going to be good for a healthy diet that they can follow. I mean, if you put me on an 800 calorie diet, I am not going to follow it, and if I can't have a little bit of ice cream now and then again, I'm probably not going to follow that too. So I think exercise is also a big one, and I'm sure you teach in your exercise class. You have to find where people are. When I first got out, I was very go 60 to 70%. You got to be in this range, and it doesn't work for everybody. And I've learned over time to meet people where they are, listen to what they want to do, and so helping with that. And then I was a lead author on the physical activity and exercise recommendations for stroke. So if you've had a stroke, we have the American Heart Association has a scientific statement out there to help people after stroke what they need to do. But ultimately, let's prevent them. Know your numbers, watch your vital signs, get plenty of exercise, eat a good diet, and sleep.
And I mean, just in general with exercise, I mean, is there any specific guidelines that you would recommend? Really, is it more cardiovascular, resistance training? I mean, what are you, as far as the type of exercise, maybe the intensity, the duration, just some of those? Like I said, we don't have to go into every component of that, but just if somebody's wondering, well, what do I do? Like, what type of exercise? How long? What's the frequency? How many days during the week?
I mean, I think you have to follow the WHO guidelines, and that's be active most days of the week. Again, I think you have to, I'm going to go back to, I'm very big on you have to meet people where they are and what will they do. So if they're willing to walk and be more active throughout their day, I think that's better than being sedentary and, maybe doing a hip bout for 10 minutes. So if you can move more throughout your day, that's really good. However, that said, if you want to reduce cardiovascular disease and the incidence of stroke, getting in the moderate intensity zones of aerobic exercise is really going to help your heart and your brain and your vessels stay the most healthy. And so again, in that 50 to 75% of age-predicted heart rate max is kind of a nice zone to be in. I always call it my jogger-slogger zone, so that I'm just doing this. And again, I think if you can do this 4 to 5 times a week, get 150 minutes of moderate intensity activity, that's great.
Right.
Now, there's a lot of evidence showing, and we're testing it in stroke, does high-intensity interval training, is that beneficial? And so, again, if you're in those higher intensity zones, you only need to meet 75 minutes a week. So I like to work in a little bit of both, have a variety and cross-train. It helps avoid injuries. Now, I don't know that resistance training will prevent a stroke, but what I will tell you is resistance training is great for aging. Muscle strength, it helps with balance, and
decreasing
it just keeps you strong and fall risk. So, I don't know that it's in stroke prevention, but, if you build muscle, your metabolism is higher, it helps you keep the weight off. So I think it all works together. Right. But again, the most important one is the one that you're going to do.
Yeah, that's true. Find something you enjoy. When she says aerobic exercise, of course, it's find an activity you enjoy, whether it's swimming, jogging, walking, cycling, an activity you enjoy, because if you enjoy it, you're more likely to stick with it. And like you said, 150 minutes a week, divide 150 by 5, that's 30 minutes a day. So 30 minutes a day, Monday through Friday. Or if you want to work out a little more intensely at a little higher heart rate, or do intervals where you work at a higher heart rate intensity and then a lower heart rate intensity, and a higher and a lower, and you alternate, 75 minutes a week, divide that by 3 days. So you're looking at 25 minutes of doing those intervals on, say, a Monday, Wednesday, Friday. And then, like you said, to kind of keep it from just getting routine and boring, maybe 1 week you do your Monday through Friday, 30 minutes each day. The next week, you're like, well, I'm going to back off the frequency, do a Monday, Wednesday, Friday, 75 or 25 minutes of intervals on each one of those days, right?
Yeah.
And some of it's, what you have going on that week, and you have all these other things in your life you got to work around. Like I said, maybe you're a single mom, the kids and the job and this and that, but you just find ways to work it in. And I think it's important for people to realize you don't have to make all these changes all at once. I've talked about this in other videos I've done. Just start making small changes to your lifestyle now, and they'll add up over time. It's like compounding interest for your heart and your brain. Just small changes, little deposits daily, and that's going to lead to big changes and hopefully prevention of some of these neurological and cardiovascular issues over time.
Starting exercise at any time is good, but if you can maintain it throughout your life, and especially middle age, we're finding is really critical, because as you said on the way over, you get really into your career. You seem to be, maybe moving up the career ladder. You have a family. You have a lot of competing demands. And sometimes we forget about the exercise piece, but that's really when it's sometimes the most important. And again, be willing to help guide if you're working an exercise trainer, what have you, or a therapist, think about different ways to be creative, because I cannot do HIIT on the treadmill. And, they talk about the 4 on and maybe 3 off and those intervals. I can't do those either. I mean, that's really hard for somebody at my age. But I love the 1 minute intervals. I am all in and buying that for about 10 to 12 minutes of doing HIIT, but I have to do it on an elliptical. I love the elliptical. I don't like the treadmill. Yeah, so, again, find the thing that you like. And now I do it 2 times a week. And, when I cycle, there's a little bit of HIIT as you go up and down hills. But again, sometimes it's the things we don't think about. Stairs, if you want to run up the stairs or take the stairs a little more quickly, that's a HIIT bout right there.
Now, you did walk across the entire state of Kansas a while
I did
back.
Do that.
Have your feet recovered from that?
Yeah, that was, I walked all 570 miles. My son and I, we did it in 23 days. My feet were sore, and they started swelling. I had a little bit of neuropathy.
I can remember, because I was up at the med center at that point, and I was like, oh my gosh. Now, you didn't do any intervals when you were doing that, right?
No, that was the slogger mode.
Yeah, because of the duration, we're not going to be doing intervals walking across the state of Kansas.
No, that was a lot of consistent walking, 26 to 30 some miles a day. Yeah, it was a low intensity. Well, you're carrying your, we backpacked it. So we didn't have any support team. We backpacked it all the way across. There is a Santa Fe trail out there if you want to take it. It's really neat to see. You can drive there and follow it and go to all of the points. But it was really fun.
All right. Well, let's shift gears now, and we'll discuss the 2023 paper you co-authored that was published in, now this was Journal of American Medical Association Neurology.
Yes.
Titled Optimal Intensity and Duration of Walking Rehabilitation in Patients with Chronic Stroke. So can you provide some background info on this paper and maybe talk about, why the research conducted was important?
Yeah. So this is a multi-site trial. You can see here with all the list of authors and everything, there were 3 sites. There was KU Medical Center, University of Delaware. Dr. Darcy Reisman was the site PI there. And then Dr. Pierce Boyne, who is the overall principal investigator and lead on this, and he's at the University of Cincinnati. So the 3 of us really have had a big interest in exercise, thinking about heart rate, intensity. Again, I think there's several of us that really believe that intensity matters. What do you do? Getting your heart rate into certain zones to really benefit people recovering stroke. And then we have this aspect of it's walking rehabilitation. So we're getting people on the treadmill and practicing that walking. So that was really the background of the study is, again, if we think about practicing the technique we want them to get better at, how can we optimize this, and how can we make this happen? And Dr. Pierce Boyne has done a lot of work on some of the growth factors you talked about. He's done various HIIT bouts. He's done short interval. He's done long interval. He's done short duration, long duration, and so he's been trying to find really this ideal walking intervention that might upregulate VEGF. So again, vascular endothelial growth factor. IGF-1, insulin, what is that one? Insulin growth factor, right?
IGF-1.
And then BDNF, so brain-derived growth factor, neurotrophic factor. And so these are sort of the three markers that people are looking at. We see them in the periphery. We see they go up with exercise, and they're intensity-driven. Yeah. So if we can get people with stroke doing a lot of walking repetitions, we can upregulate these factors that might help with recovery. Can we make people recover more efficiently or faster? And this trial, that's the background on it, and that's kind of the premise behind what we wanted to do. And we're all the PIs on this are physical therapists, and so we've been in the clinics, we've watched the slower progress, and we really want to drive this forward to help people recover from stroke.
Yeah. All right. So what was, I guess, and you kind of hit on, you provide a lot of good background there, but just in general, the bottom line purpose of the study.
Yeah. So one of the things that we don't know is, again, if we look at intensity, so we're trying to find the optimal dose for walking rehabilitation. And that included both duration and intensity. And so those are part of the FIT principles: frequency, intensity, time, and type. Mm-hmm. So for our type, we're doing treadmill training. For the frequency, we did it 3 days a week, and then the time was 45 minutes. So this is intensive. So we start out with 10 minutes of overground walking. So we get everybody, regardless of group, overground walking. Then we get them on the treadmill for 20 plus minutes, and then walking, I think it's 25 minutes, and then 10 minutes back overground. And the thought is, if we can get them on the treadmill in a safety harness and get them going faster in the high intensity group, then maybe that will help when they practice it over ground. So we had two groups. People were randomized either to high intensity interval training. And again, this is based on their fastest walking speed. So again, it's driven by walking, not necessarily heart rate, although we looked at the heart rate zones and tried to get them in those, but it was based on their fastest walking speed. Or they were in the MAT group, which was the moderate intensity aerobic training group, and they would walk on the treadmill. And this wasn't driven by speed, but by a heart rate zone.
Right. Right.
And again, 3 times a week. And then for the dose of, do they need 4 weeks of training? Do they need 8 weeks? Or is 12 weeks optimal for this type of training?
Right. Yeah. And I know that moderate intensity, the MAT group that trained at a moderate aerobic exercise intensity, they were typically between like 40 to 60% of their heart rate reserve.
Yes.
And then those that were in the higher intensity group were obviously above 60%, correct?
Yes, yeah. 60 to 80% of their heart rate reserve.
Okay. All right. Well, a little bit about the methods used. Talk about that, the study design, the settings. We said it was multi-center.
Mm-hmm. And they were in research labs. So this was not at the clinic. This was all in the research labs. Uh-huh.
And then, I don't know, maybe if you want to provide any information about kind of the demographics of the participants, what types of strokes they had, how much, disability. I mean, just any little tidbits you want to add there about the participants or subjects, and then the interventions as well.
Yeah, so for this study, what we did, again, this was a randomized controlled trial. The assessors were blinded, which meant they don't know what group they were in, and obviously the people who were doing the intervention and the participants knew. This was in a research lab setting, again, as I said. And then the participants were people with chronic stroke. So they were greater than 6 months post-stroke, but we actually had an end cap of 5 years. So again, maybe in this, 6 months to 5 years when people are getting adjusted and at home, maybe we need to encourage them in outpatient therapy. So we took people 6 months to 5 years.
Okay.
They had to have a walking deficit. And so that was either by their gait speed, their walking endurance, they had some hemiplegia or hemiparesis or weakness, or they said, yeah, I don't walk and I can't keep up with my peers. And so we would test them. So they couldn't walk faster than 1.0 meters per second on a 10-meter walk test. So we wanted them to have some walking impairment. If we didn't do that, there would be a ceiling effect, which meant they're already at a high level and can't improve.
Right.
So we wanted people to have some level of a walking impairment to see if we could make them better. Now, we didn't have a minimum speed. We had talked back and forth, and on other podcasts we've discussed this, because there has been some research that showed that people with very slow gait speeds, like 0.4 meters per second or 0.3, might not do as well. But we just said, let's really test this in a multi-site trial way. And so the goal was overall to enroll 55 people, and that's divided across 3 sites. So it really is this preliminary study to see what is the dose, what is the intensity that we need, and who does this work for. So again, we assessed it baseline, we assessed it 4, 8, and 12 weeks after the intervention.
Yep, so 27 in the high-intensity interval training group.
Yep.
And 28 were allocated to the moderate intensity group. Okay.
Yeah. And I would say we did block randomize those. So just to be clear, so to make sure that the groups were balanced, that there was some magical randomization code, and so they were randomized by site, but also by their lower extremity function.
Okay.
So we didn't want one site to have maybe people who had a lot with lower gait deficits, and one site with a lot of high. So they really made sure that, their biostatistician had everything set up so that the groups were balanced across site and across lower extremity function.
Is that the Fugelmeyer?
Fugelmeyer,
yeah. Okay.
Yeah.
Maybe talk about that, what that is.
Yeah, so the lower extremity Fugelmeyer, we look at somebody's reflexes. Again, if they have reflexes or they have no reflexes, and that can happen after stroke. You can lose some of those reflexes, or they can be hyperactive and really heightened. Right. We look at their motor function, how well they can maybe pull their knee back while standing up, how much their strength is, the movement in certain patterns. And so typically the therapist does screen them for this. And then we also look at coordination and timing. So all of that adds up to a score of 34 for the Fugelmeyer, the maximum score. Okay. And if you look at the one of the tables, I don't know if this is figure 2, but if you look at the baseline, the groups were equal across sites. So there was no differences between the 2 groups, which is what we really wanted.
Right. Yeah. At baseline. Yeah. You can't have those differences at baseline, or you're not going to see changes. Right. Yeah. So, and it looks like you had a mix of different stroke types. I mean, obviously, more had the ischemic stroke type. Some were hemorrhagic, but you had a good mix in both groups, both the high intensity and the moderate intensity.
Yeah, we did. There were no differences in medication use. I mean, everybody's, like we've talked about, they're usually on statins or maybe heart medication. We had a nice mix of...
BMI very similar.
Yeah, BMI was similar. I would say, race and ethnicity was similar across the groups, male, female. We tried to make sure. And then the age also, because, again, we're recruiting 40 to 80 years of age. So we had very similar groups
63.
Across that. Yeah.
Age 63 for the average in the high intensity group and 61 for the moderate intensity. Yeah, very... That's good. That's good baseline data to have when it's similar between groups. Really, really good, especially with all these variables too. That everything you're looking at here. So, all right. So, moving on now to the. I guess maybe we'll talk about the main. Just the main outcome measures that were assessed in this study. And you mentioned the time points again. Maybe just reiterate that. What you were looking at and the time points.
Yeah, so the primary outcome on this was walking after stroke. So we used the 6-minute walk test, which measures how far you can walk in 6 minutes. And so on average, I think stroke is about 230 meters post-stroke, whereas like a healthy adult is about 500 to 600 meters that they'll cover in that 6 minutes. So again, people with stroke do have walking deficits. But yeah, we looked at walking outcomes. 6-minute walk test was the primary. Then we also looked at...
So you did a baseline 4-week, post-stroke, or not post-stroke, baseline, post-intervention, 4 weeks, 8 weeks, 12 weeks.
Yes.
Yeah.
We looked at gait speed, so with the 10-meter walk test, which is how fast can you walk. And I will say the 6-minute walk test is really community endurance. Can you walk around your neighborhood or a store?
Yeah.
Gait speed is more like, can you cross the street when the light light to get across? Can you do that? So again, the 10-meter walk test, how fast can you walk? And we did a normal walking pace and then their fastest walking pace.
Right.
So again, can you get up and go if the light's going to change? And then we also looked at fitness. We looked at fatigue, and we looked at an anaerobic threshold. So we looked at a lot of things, and not reported here. We also looked at their physical activity measures with a stopwatch, which we're working on that paper now. And so we have quite a bit more variables, but these were the primary one that we wanted to address.
Yeah. Okay, so we'll get into a little bit of the results here. So we'll pull up picture 7. So this figure is looking at basically the treatment intensity in the different groups. So you see obviously they're in blue, either they're blue closed circles or the blue open circles. That's looking at the high intensity interval training group. And then I believe the cross or the plus sign represents, I'd have to go back and read that, but maybe treadmill training?
Yes.
And then you have in orange there, the closed orange circle, the open orange circle, and the plus sign. That's going to be your moderate intensity exercise group.
And you can see, at baseline, if we look at on the x-axis there along the treatment session, so 1 would be their first visit and 36 would be the last visit after the 12 weeks. And then we have a percentage along the y-axis there of their initial, at the screening visit when they came in and did their walking test. We're looking at in this A, their training speed on those first visits all the way 30 through 36. And so you'll see that in the yellow or that orange color, the speed, it starts out lower, a lot of variability, but then it really tightens over time, and they actually get up to about 100% of their baseline walking speed. Now, you have to remember when you're looking at this graph, though, we don't allow them to go over 60% of their heart rate reserve. So we're sort of blocking them from kicking up their speed because they need to maintain their heart rate. So their speed is actually going to be kept within this heart rate zone. Whereas the HIT group, again, the goal was to walk them as fast as possible. We actually did this where we'd walk, and I should probably explain. So the first interval of HIT was 60 seconds long, and then 60 seconds of completely stopping. And then 60 seconds of exercise, 60 stopping. And then we started going 30, 30, 30, in that. And it was really fast. It was quick bouts to try to get them at that fastest speed. Right. But people with stroke wear out. They get tired because they're working so hard because it's hard work to walk when you have, affected limb. And so, we gave them shorter rests, but these bursts were very intense but short. And so, again, you can see that this HIT group, right away they were already above 100% because we're pushing them beyond what they're comfortable. Right. And the treadmill is going to be even easier to do that because we have them all in a harness and overhead system, and so they feel safe and secure. So you can see in the pluses how that really increases over 36 weeks. Now, what's fascinating is the overground, too. Mm-hmm. And we didn't measure confidence here, and I'd like to in our future work, but I think as they got more confident and comfortable, they were like, okay, I'm willing to do this over ground with you. So that was really important. Yeah, that might explain that difference between the two lines, the pluses in blue and the circles in blue. Yeah, just having that confidence, that's such a huge thing. Like, all right, if you're confident, I'm going to go faster. I have this support on, right? Yeah. But even the confidence in doing it over ground increased.
Right.
You know, they're at like 150, 160% of their baseline walking speed.
Yeah.
And then when we look at B here on the right for us here, we have, again, treatment session, but then we look at their percentage of the heart rate reserve. And so, again, we had a few people, you know, early on that were below that 40, but by the end, we got them all between the 40 and 60. And again, you know, for the most part, we had people between 60 and 70% of heart rate reserve. And when we think of that, we had a few in 50. You know, if they had a lot of impairment, their heart rate, we may not have been able to walk them as intensely to get that up. So, but again, that fastest walking speed seems to be the critical ingredient in making gains in people with stroke for walking.
Yeah. And then that heart rate reserve, if you're wondering where that is, and my students should know this, but
is there a quiz?
Right, quiz after this following, right? So, you know, your max or your peak heart rate minus your resting heart rate, and then that would be multiplied by the target heart rate training intensity. So 40%, let's say, or 60% if you're in that moderate intensity group. And then you add back in the resting heart rate. So that's the simple formula. But typically, yeah, if you're at a lower percentage of your heart rate reserve, right, lower intensity exercise. If you're at a higher percentage of it, it's higher intensity exercise. So, and you can see in that, I guess on that graph B there, obviously in the gray zone, that's your high intensity above that 60% of heart rate reserve. And then in the orange, you're between that 40 and 60%, that's the lower intensity training. So it is interesting how you talked about, you know, and that's a huge question in a lot of exercise studies when we're looking at exercise driving physiological processes, whether it's in muscle or the brain or bone or whatever tissue. It's like, okay, there's this duration component, you know, how long and what changes are occurring in those tissues, but the intensity is such a big thing. And it's like you mentioned, the different growth factors, VEGF that drives blood vessel growth, and BDNF drives neurons, synaptogenesis and neural growth in the brain. And is there a certain intensity where you get a bigger expression of those proteins, of those growth factors in the brain that are driving some of that after a stroke, or maybe, you know, prophylactically before you have one? And it's like intensity, I think, I'm glad that people are looking at intensity now, because I think that's such a key driver of a lot of these physiological processes.
And one of the things we did, we measured their resting heart rate every day, and we plug it into our iPod. And so it changed based on their resting heart rate. So again, sometimes people's heart rates change. So every day we were modifying that equation based on their resting heart rate to make sure we were getting them up in those target zones.
Yep.
Yeah.
And that's one thing you should see as you get more fit, right? Your resting heart rate should come down. Your heart's stronger. It doesn't need to beat as frequently. So anyway, going on a whole nother tangent. But let's maybe go on to the next picture here. So let's talk about this figure. So this is looking at our primary outcome measure of this study, 6-minute walk test changes over the course of this 12 weeks.
Yeah, so I think the graph on the left is the absolute distance walked between the groups. So there was no significant difference between the two groups at baseline. And again, you know, that's always important if you don't have a group difference. You can see that the HIT group within the group had a significant improvement from baseline to when we did our testing 4 weeks, where the MAT group did not. And then from...
And I think it's important just for viewers to realize it may look like there's a difference. Because if you see distance in meters, right, on the y-axis, so you see the HIT group at baseline testing, right, before going through the intervention, the HIT group was at about 200 meters, their distance walked, and then the moderate intensity group was 180. Well, again, this is not statistically a statistically significant difference, even though it may look like there's a difference of 20 meters on that graph, which there is, but that's not statistically relevant. So just to drive that home.
Yes, that is not statistically significant. Again, 20 meters in this case across these people did not show a significant difference. Again, when you look at the difference between the MAT group, so if you look at the orange circles from baseline to 4 weeks, there was not a significant improvement in that walking from baseline. But we did see that in the HIT group, which is the blue, that they significantly increased their walking distance at 4 weeks, and that there was a difference between groups at 4 weeks. But where we really see the big I'm sorry, at the 4 weeks, there was a change within the group there at the 4 weeks. And when we look at the difference, 8 weeks compared to baseline, both groups improved over their time. And what we saw is now we're starting to see that significance between the groups. And then at 12 weeks, wow, we really see that big difference in that fast walking group. And a lot of that is, again, I just want to be clear, and I really try to emphasize this because I don't want people to get the wrong message, is that, again, both groups compared improved from their baseline. So there's nothing wrong with doing moderate intensity if that's, what you're going to do at home after a stroke. But if you really want to increase your walking endurance, it looks like 12 weeks. We were hoping we'd see things at 4 weeks for our next study, but it looks like 12 weeks is the optimal dose. And the HIT seems like in this, preliminary work is, really, we see a bigger difference at that 12 weeks between the groups.
So if you can, and again, it's like you said, it's going to be tough. You got to push yourself, fatiguing, especially like if you have a limb that's weak. But it's like, if you can get to that point of push yourself walking fast for 30 minutes and back it off, or 30 minutes, 30 seconds, not minutes, 30 seconds.
30 seconds.
Then back it down for 30 seconds and then crank it up again for 30 seconds. There's your intervals. And I mean, it's, if you want to hopefully have improvements over what you would normally see with just moderate intensity, lower intensity, consistent walking, you can do those intervals. That's awesome stuff.
And so again, if you look at the graph B, it's really just looking at the change. So this is the change in meters relative to their baseline, which would be at 0, right? That's their baseline. You can see the HIT group here in this bar graph really in blue really increased over time.
All right, we'll go on to the next image here. So this is just a table, and really I've got a lot highlighted here. On the very left-hand side, you've got like that first row, the primary outcome measure that you all looked at, which was the walking capacity, the 6-minute walk distance in meters. And then below that, there's the secondary outcomes that you looked at, the gait speed and the 10-meter walk test. There's a fatigue scale score there, and then you even looked at VO2. And a lot of that I have highlighted there in yellow is just showing where there was significant differences between the high-intensity group and the moderate-intensity group at the different time points, which I don't know if there's anything you want to talk about. We kind of hit on it on the previous image, but anything you want to point out there?
Was that a pun on HIT?
HIT, yeah. No, I didn't realize that it was, but yes, it was.
So as expected, we've talked about the 6-minute walk test, but as you can imagine, if you're practicing, and again, this is neuroplasticity in practice, when you're doing this fast walking speed and these endurances, people felt a lot more comfortable. They're both over ground and treadmill. So when we do the testing over ground, they walked a lot faster, both at 4, 8, and 12 weeks in that HIT group. And then we also did the fastest walking speed on that 10-meter walk test. And again, the HIT group really shines here. We can see that. Now, I will say, I'm not sure what to make of the fatigue scale. So the HIT group at 8 weeks reported less fatigue, which, it's like, okay, this is exciting, but it wasn't at 12 and it wasn't at 4. So I'm a little cautious to say that, to make anything of that. And that's really just because we're not sure, it wasn't a big enough sample, maybe to see differences across, and maybe someone had a really good day or maybe somebody had a really bad day and felt tired at that outcome testing. So it's exciting to think that maybe HIT, even though they're working harder, might have less overall fatigue. But again, I don't think we can make any conclusions from that.
Yeah, it'd be interesting to look at things. Well, did you look at lactate and things? We measured lactate
each week on that, but honestly, it wasn't hugely different between the groups. It's coming out in another paper. One of my postdoctoral fellows, Dr. Jackie Palmer, has a paper coming out where she looked at EEG data. So looking at brain activity, intensity and lactate seem to make a difference, which, I think we really need to make sure we're pushing that intensity. And then VO2. I was really disappointed.
That's what I wanted to get in.
So we measured VO2 on a treadmill.
And maybe tell everybody what VO2 is.
Yes, your oxygen uptake. So VO2 is oxygen uptake. When we do an exercise test, we're looking at your peak oxygen uptake. And so what's the highest amount you can get at the end of an exercise test? And then there's, VO2 max, which is, again, your maximum oxygen uptake. And typically, this term, I feel like, is really for athletes or people who really go all out and are willing to push themselves. Yeah. They're going to meet the American College of Sports Medicine criteria. They're going to be within 10 beats of their age-predicted heart rate max. Their VO2 is going to plateau. If you increase the treadmill speed or resistance if you're cycling, and you see a plateauing of VO2, your RPE is 18, 19, or 20, and then you meet that respiratory exchange ratio of 1.15 or greater. And so, in clinical populations, that's hard to reach a max. So we call it VO2 peak. What's the highest amount they can get on this exercise test?
Right. And just to give people like a frame of reference, and I know I talk about this in my classes, but, I say typical college-age student, 21, their VO2 max, their body's maximal ability to consume oxygen, not only in the lungs, but being uptaken at the cellular level, right? It's being extracted and taken into the cellular level because that oxygen helps you produce energy in your cells. But it's typically around, 35, 40 in a college-age female, and 45 maybe in a male. There's some
physically active
size and lung difference there, but it's typically around that. We'll say 40 in a college-age individual. But then, depending on your activity level, obviously the more active you are, the more aerobically fit, that VO2 max can go up. You see in endurance athletes, it's up around maybe 60, 70, really high.
I've gotten a 70 in my lab.
Oh my gosh.
Yeah.
And then, so your ability to extract that oxygen improves as you become more aerobically fit, right? And that's going to enhance your energy production and everything else in your body. And then you see, what do you typically see? It's a loaded question, I know the answer, but I'm going to let you answer. Like, what do you typically see post-stroke as far as how does that affect someone's oxygen uptake?
Yeah. So one of my colleagues had a friend who was a marathon runner. And he was in his 50s or 60s, and he had a VO2, I think, of 52. He had a stroke, and 6 months later they tested him. It was 28.
Oh, man.
So you lose a lot from bed rest, just the stroke itself, movement. You have a higher energy expenditure. So your VO2 at the same activity, so if we had two people walking at 3.8 miles an hour, the person without the stroke would consume less oxygen because they're more efficient than somebody with a stroke. So it's not uncommon for people post-stroke doing activities of daily living to be at 50, 60, or even 70% of their VO2 max because they have to use a lot of energy to work. But typically what we see for VO2 maxes in older adults with stroke, we typically see anywhere from 10 milliliters per kilogram per minute to maybe 22 at the most, but usually it's between 11 and 15 is what we see. And just to give you reference, when we think about older adults, so to do your activities of daily living for women, a VO2 of, you need 18 milliliters per kilogram per minute to have that capacity, and then men is about 21 to 22. And so if people with stroke are at 11, 12, and 13, compared to their peers, that's why they're expending more energy.
I think you even receive, now correct me if I'm wrong on this, but even like if you're below 14, aren't you on medical disability for that? I mean, can you not, like if it's less than, I was thinking there was a cut point there somewhere.
There probably is just for the ID, but I don't know if you get any Medicare or anything for that, because we have a lot of people with stroke at 9, 10, 11.
Yeah.
Now, I will say, again, this is a treadmill test. And so the hard part is sometimes the tests are shorter due to safety with walking or loss of balance. And so we might not be testing the maximal capacity of their cardiorespiratory system because we have to stop the test due to safety.
Yeah.
So, in my intro, you talked about the development of maximal and submaximal exercise tests. So I use a recumbent stepper for people with stroke, and this is where I teach internationally and even nationally is how to implement this in stroke care. And so we take away that balance piece. And so I have hit RERs of 1.1 And their VO2s are a little bit higher, but it's still impaired. And so, we didn't see any improvement here, even though we saw the improvements in their walking speed and walking endurance. When we really need to push them to those peak points, it's hard to reach those. And we didn't see a difference between groups.
Yeah, I wonder if you might have seen him, like if the study was even longer.
Then you have
those
retention.
improvements,
That's
then it's
hard.
retention issues.
It's
all
hard.
because you had some attrition, which you're going to have in any study anyway. People dropping out, but that's difficult to do. And I really liked how you drove home the point. And I talked to my students about this. When we think of, it's young, healthy students, most of them in general, and it's like when they think of exercise intensity and high intensity exercise, it's that running that that 5K. Or that 10K, and the heart rate's real up here, and you're cruising, you're running along at a fast speed. Yeah, that's high intensity for you, but this is all relative. Somebody that's had a stroke. If you're young and you're active and you're fit and you're running that 10K or that 5K, your oxygen consumption may be really high, 50, 60 milliliters per kilogram per minute. But then you have a stroke, and just walking from one room to another, and doing some of those activities, whatever you're doing in the kitchen, cooking, moving around, you could be up like you said, 50, 60, you could be at your max. So the intensity is so relevant to the individual, right? So it's important to remember if you're going on and you're working with individuals that have suffered, a stroke or some other injury. So
or have a disability or something, not a stroke or deconditioned. Again, it takes a while to get that training effect, and so again, people are going to be fatigued earlier. And I think that's an important message to think about. Is we always tell people, yes, you're going to be tired at first because your body's not used to this, and you're going to be sore, but you're going to sleep really well, and give us some time to adapt. And usually we see people that really do then enjoy it after that.
I think of my grandpa Taylor on my dad's side, and he had COPD, smoked for years, but him walking up, he used to do a lot of woodworking in the basement, him just getting up that flight of steps. I mean, it was amazing. That was like high intensity max exercise for him, even with his oxygen, with his cannula in the tank, he'd get to the top of the steps and I can still hear the pursed lip breathing and the, and that's, again, intensity is relevant, or it's all related to the individual and their function and fitness level. So
personalized exercise prescription.
Yes, very important. All right, so basically, what is the bottom line, the conclusions and relevance of this study?
Yeah. So, I think for this trial, when we think about locomotor exercise, locomotor hit, or, you're walking, people who are living with chronic stroke, 6 months to 5 years, we definitely think that this vigorous or this high-intensity interval training really appears to be a significant and a driving factor of, walking recovery when we compare it to moderate intensity. But again, I just want to point out, and I can't emphasize it enough, is just that, doing HIIT without a treadmill and a harness is difficult, and the group moderate intensity also improved. So again, doing something is better than not doing anything. And I would imagine if we had a control group that was sedentary, these two groups would look better than that. So again, I just want to give the shout out for something is better than nothing. But in this study, the vigorous training definitely helped with walking capacity, fast walking speed, and all of that. And so far, it seems like we need 12 weeks of training. I do want to say that the people who had a slower walking speed of 0.4 meters per second actually had the greatest gains than those people that had the faster walking speed. So I'm glad we included them. It seems like they made the most benefit, which has not been shown before. So we're working on a paper with that. And really making sure that we're targeting, recruitment around people with slower walking speeds, because it seems like they benefit the most. But 12 weeks seems to be the number in this preliminary trial, this early trial. So we do have HIT Stroke 2 that's going to be starting July 1. We got refunded from the National Institutes of Health, or the NIH, to continue this study. We'll be testing, again, the same study design, HIT versus MAT. We're essentially I think, tripling our sample size. So we had a total of 55, and we have to get 55 at each site now. And with that, we will be doing the 12 weeks. And so with more people, it'll be interesting to see what we find next. Maybe we only need 4 weeks or 8 weeks. Maybe we'll see some changes in VO2 this time and things like that. So we're really excited to drive this forward.
Greater statistical power. Yeah,
Yes.
you could potentially see some other changes there.
Yes.
Yeah, and I think it's really important. I guess my last little tidbit that I just thought of is like, it's when I go back and think about, the participants in the study, obviously they were in the chronic phase, 6 months out to, like you said, 5 years.
Yeah.
So if you've had a stroke, even if it's 5 years ago, I mean, it doesn't matter. Like, you get active, exercise,
Absolutely.
push yourself, and you'll likely see some improvements. So, I mean, it's just, because I think a lot of people, they get in this mindset, and I sympathize with them. Obviously, I've never had a stroke. I don't know what it's like to be in those shoes, but I think it's easy for some people to just want to give up and think, oh, it's been too long. It was 5 years ago. Nothing I do is going to matter. And that's not necessarily true. So,
well, it depends on how long ago and what the messaging was. I mean, times are changing, and research is showing that you can make improvements and that you can get better. And so, again, I think the message is keep moving, stay active. It's never too late to start exercise or being active or practice things to see those changes appear.
Challenge your brain.
Yeah.
I got a ping pong table that my daughter doesn't seem to want to play much ping pong with me. So come over and play ping pong if you haven't done that before.
There you go.
Get some of those neural pathways fired up that maybe haven't been active, right? Work on your reaction time and
all sorts of fun things. Yeah. Absolutely.
So how can people contact you if they have questions about stroke rehabilitation, or your research and lab?
Yeah, I think if people are interested in participating in a study, we have a few, as I mentioned, we're going to continue with our HIT Stroke 2 trial. So they can call the laboratory at 913-945-6630. If they have some interest in shadowing in the lab, let's say people want to learn what research is, they can reach out to me at sbillinger@kumc.edu. And if you just want to know what the lab's doing and what all we have going on, you can follow me on Twitter at Sandy_ReachLab.
Awesome. I like it. Basically kind of an open door policy, right? Like, come check it out in a way.
In a way.
In a way, yeah. Okay. Well, if you have questions for me about the KU Exercise Science Program, send an email to jtaylor@ku.edu or call 913-897-8516. And as always, thanks for watching this episode of Fitness Facts.